We'll get going now. Thank you very much for coming to this session, which is about, when the magic people in the back send in, is about patient-public involvement in, oh, that's not us. Oh, that's not us either. That looks suspiciously like John Simpson for later. I'm not even going to attempt to do yours, John. That's well above my pay grade. We're going to talk to you about patient-public involvement. Involvement in diagnostic research and innovation and what difference it can make. My name's Kasia Karowska. I'm going to give you a viewpoint from it as a PPIE professional. I've spent the last 5 years working with the MIC, now the HRC, supporting their PPIE, but I've recently moved to that role, which is too long to mention. And then Rachel's going to give you a researcher's perspective on how it's made a difference in the HRC. And lovely Rosemary and John have also come here to give you a patient-public perspective. And we wouldn't be doing our job if we didn't include them as equal partners in this presentation. So I'm just going to start very briefly with this very dry slide of what we mean by patient and public involvement. We use the NIHR definitions. Involvement is research being carried out with or by members of the public rather than to, about, or for them. It's about an active partnership between patients, carers, and members of the public with researchers that influences and helps shape the research. Engagement, often referred to as public engagement, is where information from researchers and knowledge is shared and disseminated to public and patients. That isn't about writing a journal, an academic article or going to a conference. This is about getting out into communities and actual members of the public or patient groups and talking to them about the research. And participation, which often gets forgotten in our attempt to try and convince everyone to involve people, but participation is about taking part in research studies. For example, being part of a clinical trial, being part of a qualitative study, completing a questionnaire, or being part of a focus group. Participation and involvement sometimes get mixed up, so that's why the NIHR have tried to define them. Public involvement and engagement matters regardless of the research focus. So I've spent the last 5 years helping the HRC understand where patient-public involvement can make a difference in them, both as a research organisation and their research projects. But obviously a lot of what the HRC does doesn't actually involve participants. It doesn't involve patients. It's often care pathway analysis, interviewing clinicians. It might be research focused on evaluating big patient data or AI projects, or it might be lab-based. There's an old saying that's been around a very long time in patient groups, nothing about us without us. And that, I suppose, is our message to you today, that it doesn't matter what the actual research activity is. You're doing that research to benefit patients and the public at the end, and so they should be involved right throughout your research. This is a really basic research cycle, which you'll all be very aware of, and it goes from identifying and prioritizing a research question right through to evaluating it. This next slide is busy, forgive me, we will send the slides out, but these are examples of how you can involve people right through your research cycle, and different areas they can make a difference, and also different examples for you. Funders like to see layers of patient-public involvement and engagement now. And in that question that you will see in some of your funding bids, they want to see how you're thinking about the whole research cycle. You're not just thinking about going to them at the start and then talking to them at the end. I've put in red where participation comes in and where engagement comes in, just to be clear on those definitions as well. The rest of it is all just about involvement. And my last slide is this. This is the Pooh story. This is the one that I feel makes a real example of how people can make a difference in research. There's a group called PIMS. It's a PPI group based at Newcastle Hospital Trust looking at musculoskeletal conditions. In fact, I can see there's a member of the audience who's in it. Hiya, Dave. I know you're involved in this PIMS group. I wonder if you know about the study I'm going to talk about. It was about 5 years ago. They were a group of researchers were designing a piece of research, and as part of it, they were going to ask participants to give a small sample of tissue from the top of the thigh a blood sample and a poo sample. And they were really, really worried, this research team, because of the ask of the piece of flesh. And then they went to this PIMS group and they said, we don't care about the little bit of flesh. In fact, a lot of them are dealing with rheumatoid arthritis and other really painful conditions. That didn't bother them, but they felt it was really embarrassing to bring their poo in a pot to something. And it just gave that research team a different perspective. I've talked to Ken Baker, who led that research. He's absolutely convinced that led to better participation in their research, which led to better outcomes for the research, which led to patient benefit in the end. So the poo story is the one that always sticks with me. If I'm ever having to argue with a researcher about the importance of involving people in research, it's the poo story. And over to Rachel for a researcher perspective.
Thank you, Kasia. Good afternoon. I'm Rachel Dickinson, and I'm the Communications and Engagement Manager at the NIHR Health Tech Research Centre in Diagnostic and Technology Evaluation. This is a great opportunity really to thank our Insight panel for patients, public and carers, who we've been working with now for over 3 years. So they predate our HRC when we used to be the Newcastle MIC. And they've been very valuable, provided a lot of valuable input into all aspects of our work. So we've used a bit of a flexible approach when it's coming to working with them. So we have meetings with them every 3 or 4 months. And these meetings can take place online or they can be in person, kind of depends on what is most convenient for the panel. And then there's also opportunities for them to provide feedback over email and phone call as well. They've been involved really in all aspects of our work. So that includes helping to co-design our newsletter and sections of our website. They've also played an instrumental role in our successful bid last year to become HRC, so they really helped with developing that proposal. And then they've also played an instrumental role in individual research projects that we've had as well, with other academics and also with companies. So thinking back earlier to this morning's session with Eduardo from Upfront Diagnostics, the Insight panel were involved in that project, providing a kind of public perspective. This is another example of a current project that the panel have been involved in throughout the whole project. So this is a project that's funded by the Applied Research Collaboration for North East North Cumbria, another NIHR-funded organisation. And it aims to prioritise and identify the unmet diagnostic needs in care homes. Early on when we were developing the grant proposal, we met with members of the Insight panel and some other carers and relatives of care home residents. And they really helped us kind of think through how we would embed patient and public involvement throughout the project. So for example, originally we were thinking we might cost in one lay representative into the grant proposal, but the panel suggested that actually we might want to cost in the whole panel basically into the grant proposal in order that we could gather a broader range of views. We also discussed the research plans with the panel, and originally this project was going to involve interviewing care home residents. And when we were originally putting the proposal together, it was during the pandemic. So these interviews would have taken place online because it wasn't feasible to interview people in person. And the panel highlighted that there could be some digital comfort issues associated with having, with interviewing from the care home residents' point of view. And they suggested that instead we might want to interview care home managers instead. And that would maybe overcome some of those issues. And it may also mean that we would potentially identify a larger number of unmet needs. So we made those amendments, and the proposal was successful. And then we've also, the panel were very helpful when it came to shaping the questions that we were going to ask in the interviews with the care home managers. And they provided a bit of a sense check on some of the language that we were going to be using. So for example, one of the phrases that we use quite routinely within the team is a near patient test. But the panel highlighted that that could be a bit confusing because you don't get a far patient test, and that instead, actually, maybe we might want to think about using the phrase test used close to a patient, which we thought that was very helpful, and we used that language then when it came to submitting our application for ethical approval. And then also when we were having the conversations with the care home managers, that was really helpful kind of terminology to use. And then more recently, they've helped shape some of the communications that we've been sending out with around the kind of the outcomes of the project. So for example, recently they reviewed the impact story that we wrote about the project for our annual report for the NIHR. So that's just one example, really, of a project that they've been involved in and all the very valuable input that they've provided throughout. We found that funders are really requiring people at an early stage when they're putting their applications together for researchers to be providing detail on what patient public involvement they've already done, and also a clear and thorough plan of what patient public involvement they're going to have in their projects. So we feel that involving patients and the public at that very early stage really helps to kind of improve the kind of quality of the grant proposal and hopefully increase the chances of a successful funding application. And I think that the example I've just described really illustrates how involving members of the public can also improve the quality of the research throughout the project by providing that kind of fresh perspective and a kind of friendly critique of the sorts of plans and methods that you're thinking of using in your research. So I'll now pass over to Rosemary, who's going to talk a bit more from the public perspective. Oh.
Right. Hello, I'm Rosemary Nichols and I'm a member of the public. And I'd like to explain why I believe the perspective of a member of the public can add value to the development of diagnostic research and how this can be achieved in practice. Increasingly, research funders require evidence of patient and public involvement in project design and development. This is because it's effective in improving its quality and the relevance of the research to the people whose health it aims to better. In a 2018 report by Danielle Stacey, the Chief Pharmaceutical Officer and Clinical Fellow at NHS England, she included the statistics that up to 50% of patients weren't taking their medicines as intended, and that 5 to 8% of hospital admissions were medicines related. This must mean that considerable amounts of money and professionals' time are being wasted, and that there is an enormous scope for involving patients in research to find better ways to use our resources. And their insight is surely crucial in making progress. I suggest there's equal benefit in gaining the perspective of engaged members of the public who may not be patients in a particular context, but can bring a broader external view. I joined the McInsight panel several years ago and have been able to ask researchers pertinent questions, such as, why have you chosen these particular methods to achieve your stated aims? Have you considered the ethical issues that your methods may raise? Who do you think the stakeholders in this project are, and how will you ensure that their voice is heard? My perspective is informed by courses in social research methods that I took in my youth before a lifetime in education. Other public members will have different backgrounds. It's challenging to present examples of exactly where lay people's input has had a powerful impact on the design of a diagnostic research project. This is partly because the details are confidential, and partly because our painstaking approach is quietly methodical. When we're asked to review a plain English summary, we're given a deadline and we give the task full attention for the day. If we're meeting a researcher on Teams, we read material emailed to us and prepare our questions. Very often, we public members find ourselves meeting at other forums, and further experience develops our skills. At present, reward comes by backs transfers, vouchers, prize draws, or heartfelt thanks. But the variety seems to have no impact on the enthusiasm shown for the task by my many colleagues. Payment enables more diverse community members to participate, though, and this strengthens the research. A consistent feature of successful partnerships of researchers and public members is the respect with which the lay contributors are treated. From our early days in the role, we have developed expertise, and the MIC has been outstanding in its recognition of what we can offer to researchers. Thank you.
Hello everyone, you can relax now. I'm John Bedlington. The Bedlington is a town in Northumberland. I was often confused when I was working in the fire service with someone called Ashington. And the difference is that if you're in Ashington and you're furloughed, there's a dog following you. But if you're in Bedlington, you don't get furloughed. We speak English. Anyway, that's a stupid joke, isn't it? I'm going to take you on a journey, really, from when I started and tell you about research and patient participation and involvement. I was in the Royal Army Medical Corps in 1964, and we had bags with our treatment in it, and we had penicillin and aspirin, and that was all. Whatever was, and your bandages, whatever was wrong with you, you got either penicillin or aspirin. And if one of the patients, so mainly somebody in the armed forces, said, I'm allergic to penicillin, you still gave them it. And when they did research on these things, it was mainly the armed forces that did research in those days. They would give everybody penicillin in a whole battalion and see how many people had hives and things, and that was how they did research. When they did the nuclear bomb, Hiroshima, they actually had sailors lined up different distances from the bomb to see how it affected them, the radiation. And that was how they did research in those days. It's come a long, long way from then, and I've seen it change over the years. The first time I noticed that it became basically a requirement was when masters and PhD students had to involve the public in their research, and they generally did it by sending out questionnaires. And you would get something like 12.5% return, and that was considered pretty good if 12.5% of the people actually replied. You know, now it's an absolute requirement for any research-based degree to have the public involved. And the MIC, and I'm going back a bit here to acronyms. I still don't know what MIC means.
HRC now, though.
Yes, it's changed, thank God. The MIC, as Rosemary said, has involved us a lot in research, and we're now, it used to be a tick box exercise, I've said, it now certainly isn't. It's now a requirement, and that's really good. When I did my Masters in Sunderland in 95, I was in the fire service then, and I got 32% response rate from the questionnaires, and they put flags out. They thought that was absolutely brilliant. Now we get 100% response rate from our public and patient participants. So, what happens in the MIC is that Rosemary said about the rewards, the financial rewards. To me, that isn't a big thing. I'm the chair of Liver North, the National Liver Patient Support Group. I'm not a liver patient. We have 2,500 members, and I'm a patient advocate. And I do it to make sure that their voice is heard, basically. And because there is a huge stigma of liver patients, and I'm doing my best to, fight that. I comment on the patient information sheets. We comment on whether or not we think the research is worthwhile. We comment on all sorts of things. They ask us all sorts of things. In fact, we've been asked, as has been mentioned, to help with the funding proposals, and we're very successful. And that's part of it, is because we've had public and patient involvement in that. And that's something, it is a tick box, but it's a bloody big tick now that say we have actually used patients to formulate this appeal for funding, and that's great. Anyway, where we are now is we need to diversify with them more. We're old, but we were young, but we need younger people to get involved, and it's very difficult. I mean, I've got a lot of young people in Liver North. A lot of young people are getting liver disease now. It's coming more and more frequent with alcohol and drugs and obesity and, and non-alcoholic fatty liver disease. I'm not using this as a platform, but it's growing all the time. 1 in 10 people have some kind of liver disease. And while I'm on, we're talking about public participation and involvement. This leaflet here was done entirely like that. It was put out to the public and put out to our members, and there's no acronyms, there's no words you don't understand, and it's in plain English, and it's simple to understand. It's actually now translated into Polish, and we're busy translating it into Arabic. So this is all about the public and the whole universe of what the public are, to be involved in research. So thanks, and please, you will have a network of people who spread the word. That's what you're here for. Thank you.
Thank you, John. We probably haven't got a lot of time left before John Simpson takes the main stage, but we wanted to ask if anyone had any examples to share with us of how its PPI might have made a difference in your research, or if you have any challenges or questions, you can ask the panel here. So over to you. We'll get these slides shared. We didn't feel like we had enough time to go over some resources, but these are some useful resources we've put into the slide of some links to some things that might help you think about patient-public involvement in your research. But I'll go back to the questions. Has anyone got any thoughts, any comments, questions? John?
I guess start with a thank you, really. For anyone in the audience who doesn't sort of experience the PPI on a regular basis, it's quite easy, in inverted commas, to get patients who've had a disease, a chronic disease, into PPI groups because they're captive in your clinic and they've got a skin in the game, if you like. But when we were, I'm one of the directors of the HRC. One of the things that we had always worried about was what's the incentive for the public to get involved in something that's not disease specific. So my research is in intensive care. Before you go to intensive care, you're usually not that unwell. You go to intensive care, you either die or you survive to come out the other side. And it strikes me as amazing amazingly difficult, to set up ICU-based PPI groups. That's hard, but setting a diagnostics one up, that's really, really hard. I mean, where's the incentive to come along and do something in diagnostics? So I guess the first thing is to say thank you wholeheartedly, especially to the public contributors. I personally think, I'm biased, but I personally think that what these people in the front here have done is unique and is recognised by the NHR as being nationally leading, and the UK is recognised as being the best at PPIE in the world. So we have some of the best people in the world in front of us at the moment on the stage, for which we should be very, very grateful. You can feel a but coming, and this is what I challenge Kasia on all the time, is that I'm a practicing clinician, and I do a lot of research, and I have very rarely in all my time in HR and in PPI groups seen people who are in ethnic minorities. I have seen very few working mothers. I've seen very, very few people from coastal and rural communities. So I believe you are the best that there is. How are we going to go the next step and include those kind of underrepresented populations and make the PPIE groups a little more reflective of either Northumberland Street or, better still, the people I see in my day-to-day clinical practice?
Thank you, John. I'm gonna do a quick shout out for Multiverse Lab, which is the second point on there. Multiverse Lab was an attempt by the MIC and others to go and talk to people during 2021 and 2022 where they were. So we went to Northumberland Street, we went to the Quayside, we went to Carlisle City Centre, we went to Sunderland, we went up into Northumberland and asked people what their research priorities were. You can go on that Multiverse Lab link now and put in a condition like dementia or equality or mental health, and it will bring you up the voices of people telling you why it matters or something to do that they want researchers to hear. So it would be that. And I think that although that is now just a living archive, I think the message still is we need to get out and talk to more people. We need to take Rosemary and John with us and show them that it's just as important for everyone to get involved. And we also need to create more trusted relationships with groups that represent, the different groups that you've just talked about as well. But we need to do that in a way that is mutually beneficial. So lots of researchers go to community groups and say, I've got this fantastic research where it's going to make a total difference to your whoever it is, for people with dementia or people from ethnically marginalised communities. And charities and communities will say, you don't know a thing. You do not work with these people. We work with them. We'll tell you what's going to matter to them. And so I think it's important to go to those groups, but be open-minded to how you will work with them as well. And that's what we're trying to do in the next couple of years. But John, Rosemary, Rachel, any other thoughts as well on how do we get more diverse people involved?
Well, we've been talking about in the group, we've been talking about, and we've come up with organisations that we need to talk to, and they are multiracial organisations. You know, there's something called Inner Partnership, which is people from the ethnic minorities. There's the Jewish community, the Asian community, the Chinese community. We go for meals in each other's centres and we can talk to them. And there's things like Rotary Club, the Lions Club, the Freemasons, everybody we can possibly. We've talked about it, we're actually working towards it.
Yeah.
And we're coming up with a list of engagements that we need to get to people. But you're right, it isn't easy, it definitely isn't easy, but it makes each participant more valuable.
I think it's an ongoing process. It'll never be finally achieved, and we don't need to deal with that again. There is a lot of work going on, and one of my colleagues, not in the mix, she got up at 5 a.m. in the morning and went to Newcastle bin men and asked the bin men at 5 o'clock, what could we do to get you involved in research? And their answer was, you can hold it in our work time because we're not interested in giving up our own time.
Yeah.
But the effort, the point I'm making is not that they wouldn't take part, but that the effort is going in to trying to get a diverse set of participants.
Hope that helps, John. You're setting us up.
I wish we could help more.
Yeah. Any other questions or comments? No? Is everyone ready for the last part? Oh, is it coffee first? Oh, coffee first. Let's let you go for coffee. Thank you for listening. Thank you for taking the time to listen in the afternoon.